I would request Dr. Chee to take over and take it to the next level.
Okay, so when I was given this topic, I actually decided I will speak on both the subluxated crystalline lens as well as the intraocular lens. So my financial disclosure is really not relevant to this talk. So I'm just going to show you the use of Gortex, because many people look at this suture and say, how do I use this? All right, and when I show a lot of things moving around, people are very confused. So yeah, so just to show you that this comes with a needle that's kind of short and fat, and actually it's not meant for ophthalmic use. All right, so this is really off-label use for the eye. Of course, you could avoid all this by paying for a nice instrument like a micrograsper like this, going through a sclerostomy, and you just pull the suture through, rather than use this device, which we call the suture snare. So this is a very simple concept. If you have a modified Sony CTR here, and you have a suture loaded onto it, how do you then get the suture loaded onto it to your scleral fixation point? So if I had something like this, which I would call a lasso, I can throw the lasso out there, and I can pull on the lasso, and the suture should then come in. So this is actually a very simple device, which I've used the suture. It's a very, very long suture here that we have. All right, it's 46 cm, all right? And you don't need 46 cm to tie your CTS and your CTRs. So the excess suture, actually, I just thread it through this needle, and I bend the needle, all right, fit it with an insulin syringe, so I trap the edge there, so it doesn't slip in. And then on the other end, this is left long, so this can act as a lasso, and I'll show you if I had the eye in place now. It's really simple, right? I'm going through the sclera here at the entry point, and then I pull it, and bingo, right? I've just lassoed the end of the suture to my scleral fixation point through the Hoffman's pocket. All right, so this is something I conceptualized on the table without drawing. When I was faced with the problem, I created the suture. All right, so that's just what is done. It's just threaded through, and you'll see the video below that shows exactly that. But here are some tips, all right? Very important, keep the suture dry, which means that your hand should also be dry, because as you saw, I actually grasped the suture with my fingers. I'll just play this again. And I do not use forceps that will press on and crimp that suture, flatten it, and then you won't be able to get through a 27 gauge needle. It can go through a 30 gauge TSK needle as well, which I use for the pediatric mafans, all right? Otherwise, these little sclerostomies created by the needle can actually leak. So you then bend it to whatever angle you wish to, all right? Then after creating a Hoffman pocket, I use 2 mm posterior to the limbus, and I go in vertically, and when I come in around, once I've entered the sclera, I turn horizontally, and you can see I've actually pulled out that suture. And one trick is to pull back the needle once you're in. You see I've changed angle, I pull back, and then you see the loop get released. Okay, once that loop is released, you use your Coughlin hook, and then you just draw it out. So what you do with the Coughlin hook when you go in is, after putting dispersive viscoelastic to push down the capsular bag to create space, I use the Coughlin hook by turning it flat, and then I depress that capsular bag complex so that my needle does not hit the anterior capsule. This is very important to avoid ripping your capsule. Okay, so this is simple. Any questions on this before I move on? It's okay? Yep? Okay. So let's have a look at a case like this, right? You can see that there's no support there, and I've actually scanned the capsular bag with this femto. Okay, and I inject dispersive viscoelastic subcapsularly. You saw how clean that capsule was. And then now I begin to inject, okay? And you can see actually the CTR is very clean in the equator. You don't actually see it trapped in the cortex at all. Now, when you have very severe subluxation, you really need to put it in early, because your nucleus is the scaffold. You don't have to worry about distending the bag, etc., etc. All those things don't count. As long as you have the bag reasonably supported, The femto actually helps you with this in breaking up the nucleus, and you don't necessarily need to rotate this nucleus. You can just tumble it out, and then with moderate parameters, you've done the nucleus removal, stabilize the anterior chamber before you take instruments out. And you'll see the cortex is not trapped, okay? You don't see me struggling at all if you've inserted it in the plane that you have actually created a viscoelastic. Here is creating the suture snare, all right? You bend it, all right? Now loading on the CTS, so I cut off a segment first, I leave the needle on so that I can load this onto the CTS, insert the CTS, create the Hoffman pocket, all right, at least half spiral thickness because the knot must not erode through. All right, extend that loop with a Coughlin hook, hook it out through the incision, and then thread one end through, pull the two ends, leave it a little slack. Okay, you'll see why in a while. You pull back on the needle, all right, so now you have that lasso come out of the main incision. Okay, you leave it a little slack because you're going to hook it out of the Hoffman pocket. You don't want to suddenly pull on that suture. You can see it move, right? So you always leave it a little slack in the anterior chamber, and you look at the IOL for centration. So I do not fix the bag until my lens is in. It tells me exactly where that bag is. And I always tighten a bit more when you're doing 1 point fixation because that knot will settle 2 mm posteriorly from the limbus, okay? Then you have an IOL that's centered. Now this is a more difficult case. This is where you need to first start by clearing vitreous. Okay, so there's vitreous in the anterior chamber, and you know the vitreous is supporting the lens. And if you don't have a couch, actually you can just lie the patient between 2 chairs in your clinic. I remove all the vitreous that supports the lens, and I'm indenting, all right, with a cotton bud there, spear with a 27 gauge needle on the anterior capsule, and then lift it up. You can see I've got all my hooks ready. Now this is a bimanual technique, all right? So from this stage, use non-tooth forceps, not the capsulorhexis forceps, a non-tooth forceps if you're holding on to the capsule. So I do a bimanual technique, all right? And then you can apply whatever hooks you want at this stage just to provide the support. Iris hooks are easy to manipulate, and you can see really there are no zonules. You do a bimanual technique and look at the equator so that you can center your capsulorhexis. Okay, so all these are all ready. I've done my paracentesis and everything's at hand. So once you've got it to anatomical position, you don't have any vitreous, you don't have to worry about that. Again, inject dispersive viscoelastic just under the capsule, insert the CTR in this plane. So I do this 360 degrees around. And then if you wish some hydrodissection, it's not crucial, because once you've done your visco dissection in the subcapsular plane, 360 degree around, your nucleus can tumble out. Okay, this is doing a cross chop, so you don't have to rotate that much, and you can just tumble your nucleus out. In fact, my parameters can go back to normal because I've sealed the space between the iris and the posterior segment, so no fluid can be misdirected posteriorly, and we don't get vitreous coming forwards because the gap between the two is sealed. Okay, if you don't seal the gap, you don't have the hooks, or you don't have your capsular bag centered, you will get fluid going behind. You can get fragments going behind, and you can get fluid pushing forward as well, and that's how you inadvertently catch the capsule. Okay, so after creating Hoffman pockets in this case, definitely with only like 2 clock hours of zonules intact, I will need to actually do 2-point fixation. So the CTS goes through a 2.2 mm incision very easily. The 1.8, when I put it in, I just kind of curl the fixation eyelet a little bit more, and it will slide through a 1.8 mm incision, right? Especially if you're doing pediatric cases. And then this is what you've seen in already the previous video. Insert the CTS. I leave a hook there so that I can actually easily slide the CTS into the bag. You can see me entering the angle because I do not want to hit the anterior capsule when I come in. Okay, so I first enter and then I change the direction. So that's the lasso, which I explained earlier. Leave a little bit of slack. Okay, you can now position your instrument, your devices. All right, this is retrieving the sutures from the Hoffman pocket. And once you've got that done, you're going to look at the IOL for centration. So you throw 2 knots, adjust your tension until you're happy, and you don't have to tie tightly for this, okay? Because you have 2 points of fixation. As long as they're symmetrical, your lens will be perfectly centered, okay? Okay, so now let's go to IOL fixation. So I'm still going to use Gortex suture, and you can do it in various ways, whether you do it directly or whether you are having a CTR there when you just loop around the CTR together with the haptic, or you're going to insert a CTS to add to the support. So in this case here, this is a single piece monofocal non-toric lens. Okay, so first, when my hands are dry, I create the suture snare. Okay, and then I touch the eye now. As Rohit mentioned, when the eye is firm, it's nice to do your Hoffman pockets. Okay, so normally I would go to 2 mm posterior, the limbus. I used to do 1.7, now I prefer to do 2 mm. And all you need is 2 paracenteses. Dispersive viscoelastic, suture snare, behind the complex. So your other paracentesis, you use a Coughlin hook. That's very, very useful because it also extends the lasso. You repeat now going above the complex. Okay, so that's very easy. Thread the end through. You know, these sutures are so easy to handle. They're so easily visible as well. Okay, now when you tug on it, you can see the other side. Some dispersive viscoelastic, there's no vitreous there. There's a patient with retinitis pigmentosa. We're going through the capsular bag complex, extend that lasso. Okay, thread it through a fresh segment. And then we do the repeat. And we go above the complex. So this really minimally invasive is really very quick. So this for a case where there's really no vitreous presentation. And once you've got it looped around, you then retrieve the sutures. And when you've done that, again, no tension, all right? As long as there is, you know your sutures are adequately against the haptic, all right? Then you just tie 2-1-1. You can see me doing that routinely. It's the same on either side. And then you tie down 2 more throws, and you put that back into the Hoffman pocket. All right, so that's simple. Let's have a look at this other case. Where's the lens? Okay, this is a toric lens. Okay, so I'm again going to mark along the axis the Hoffman pocket, diametrically opposite sides, 2 mm, everything's ready. Prepare the suture snare. All right, you can use a 26 gauge needle, 30 gauge TSK, or 27 gauge. And then you see the lens float into view. Okay, so I'm holding on to this. This patient earlier had a CTR, but obviously that's not enough. Clear all the vitreous, as mentioned, that's the first step you really want to do. So you then get the lens into position. As I mentioned, this is the toric lens, and that's the axis. You can see the marks there. Come through posterior to the complex, go through the capsular bag at that junction there where the marks for toric axis are. Now you don't tighten too tightly and try not to widen where you puncture through the capsular bag. So this goes above the complex, and you want to balance the torque created by your sutures on the opposite side because they're placed side by side. You could do one in front and one behind the 2 mm mark as well. Okay, so I'm using forceps here, and it's the same. If you got a Coughlin hook, that would do the job as well. Okay, so you can see I've got a AC maintainer still there to maintain the pressure in the eye. All right, so now we're just going to retrieve, and it's the same. Every case is the same, but this is really minimally invasive. Okay, so once you've got that there, I will try just to fast forward this, and you'll see that actually this patient has got a really very, well-centered IOL. Okay, no vitreous in the AC. Now this was an orthopedic surgeon, and his surgeon who referred said, you know, can you preserve his lens? Okay, he's got a toric lens with quite a high toricity, please preserve it. So I marked it, and I'm matching it to the axis. So when I grabbed it, I just matched it there, and I had all my hooks ready to support it so it's in perfect alignment. Well, you know, I learned years later that this guy actually had the dead bag syndrome. He had a bit of summing ring, but I was able to even remove that from the capsule bag, open it up completely. All right, again, this is the suture snare, load a CTS, and I went in there exactly, and just next to where the support was needed, where it was really opposite the intact zonules, I actually have just created a fixation here through Hoffman pocket. Okay, I think you've seen this, so let me just go on. Right, so Gortex really is the ideal suture for suturing the modified capsular tension devices. It's strong, it's flexible, it's easy to handle, and non-biodegradable. Gortex scleral fixation of IOLs without capsular bag support is an effective rescue technique for reusing the in situ IOL, achieving excellent IOL stability. And the knot, very importantly, must be buried or adequately covered by the sclera. So make your Hoffman pocket at least half scleral thickness deep. And I use a diamond blade guarded at 300 microns. Thank you very much. Are there any questions?
Thank you, Dr. Chee, for this wonderful presentation, and it's always beautiful to see you using Gortex so beautifully. Just for the benefit of the audience, would you like to give just a small tip, you know, maybe like, have you ever seen any degradation occurring in a Gortex, and how important it is to put it into the Hoffman pocket, like, you know, to prevent the exposure?
I had a problem where I had used just a scleral groove, okay, because that patient actually had trauma going through the sclera there. And because of that, I couldn't really do a Hoffman pocket IC, so I thought I'll just get away with a groove. But that case, subsequently, the knot eroded. And what I did was that I tied a 9-0 polypropylene around the knot, and after putting a lot of povidone iodine on the surface of the eye, I rotated the knot into the eye and out again, so the suture was, the new suture actually followed the track of the Gortex suture, so I didn't have to actually go in and thread everything all over again, okay? It's what I call a suture transplant, so that's how I retrieved the other end of the suture. I cut the Gortex and then I tied the two ends of the Prolene suture, and then I didn't have problems thereafter. But it's not common.
Thank you so much. Thank you for